Good evening. Welcome this evening to the BOFAS Lectures of Distinction. This is another in the long series covering the whole syllabus for the FRCS Orth concerning everything you need to know about the foot and ankle. We have a very interesting topic this evening, and the topic is really unifying a lot of different diseases or injuries based on the pathology of the tendon. We have an expert speaker, the very experienced Rhys Thomas from Cardiff, who will talk to us about disorders of the tendon. As in previous evenings, I want to remind you that we will have a talk for about 35 minutes, and then there'll be time for questions, and you can submit your questions through the Q&A function at the bottom of the screen. And also, those of you who are collecting CPD points and evidence for attendance, a certificate is available, and the code for this will become available in the chat later on in the session. So, now I'd like to introduce my old friend and colleague, very experienced Rhys Thomas from Cardiff, who has a great experience of operating on sports injuries around the foot and ankle. In fact, I would like to say that the only criticism I can possibly think of is that he's far too good at fixing the foot and ankles of the Welsh rugby team. Rhys, over to you.
Thanks very much, Rick. So hopefully everyone can hear me and can see my slides. Welcome to this evening's talk. I hope everyone, as unfortunately we seem to be saying for far too long now, is staying safe and well, but I certainly hope everyone is. So this evening's talk is about tendon disorders of the foot and ankle. I don't have any declarations of interest with regards to this talk. So what we're going to cover tonight are the common pathologies associated with the Tibialis anterior tendon, Flexor Hallucis longus tendon, and the Perineal tendons. We're not including Tibialis posterior disease, and we're not including Achilles tendon because there are lectures covering those during the lecture series. So when we think about tendons, there's always been quite a controversy and quite a lot of discussion about what we should call and what we should use as the right terminology. And what we're talking about essentially is persistent tendon pain that impairs function. So luckily there was a meeting held last year, which was written up in a fairly recent British Journal of Sports Medicine, which was essentially a consensus meeting around the terminology regarding tendon pain. So they stated that tendinopathy is the preferred term for persistent tendon pain and loss of function related to mechanical loading. That a tendon tear, whether partial or complete, refers to a macroscopic discontinuity of a load-bearing tendon and doesn't necessarily rely on imaging. Now, interestingly, if you think about a macroscopic abnormality pertaining to a tendon, that can vary certainly between individual surgeons. And I think when we look through at some of the disease processes, we can see some of the confusion that has persisted perhaps within the literature. So let's start off looking at the tibialis anterior tendon. It comes from pretty high up on the proximal tibia and interosseous membrane, and comes down and inserts on the plantar medial aspect of the medial cuneiform and the plantar first metatarsal base, not far, just in front really of the tibialis posterior insertion. As you know, the tendinous part is in the lower third, and this is surrounded by a synovial sheath, and this passes below the limbs of both the superior extensor retinaculum and both limbs of the inferior extensor retinaculum. Vascular studies have shown that the areas under these retinaculi are in fact vascular watersheds, and this is where tendon pathology tends to occur. So what does it do? Well, by definition, and as you can understand from its anatomy, it's the major dorsiflexor of the ankle. But not only that, it dorsiflexes and inverts the ankle. And it's active during the gait cycle, particularly during heel strike, where it acts eccentrically, allowing the ankle to slowly come down to a flat foot deformity, to a flat foot from dorsiflexion. And in swing, it acts concentrically to bring the ankle up to prevent the foot from dragging on the floor. So when we think about tendinopathy, insertional tendinopathy of the tibialis anterior is a lot more commonly described than non-insertional tendinopathy. In fact, looking through the literature, there's only a fairly recent series of non-insertional tendinosis described, which was last year, and it was 3 out of 9 patients. The remaining 6 patients in that study actually had a tendon rupture. So it's rarely reported. It was postulated that it may precede chronic rupture, and the authors found that the symptoms that a non-insertional tendinopathy produced were the same as if the tendon had a complete tear. With insertional tendinopathy, there are 2 main demographics. There's the overweight 40 to 70-year-old females, and there's the runners, often those that are working up to distance running and have often increased their activity. This can present with a burning pain in the medial midfoot, which is often worse at night as the foot tends to relax down into plantar flexion. There's some tenderness and swelling over the distal tendon, and the TAPS test, where you essentially put the insertion of the tibialis anterior under maximal stretch, gives pain at the insertion site. This can obviously be treated both operatively and non-operatively. Conservative treatment methods, as with the majority of foot and ankle treatments, it can involve immobilization, orthotic provision, activity modification, and also PRP has been shown to have some success in this area. Surgery is a little bit like treating an insertional Achilles tendon tendinopathy. The main literature talks about detaching the tendon, debriding the insertion, and reattaching it just proximal and dorsal on the medial cuneiform to take a little bit of the tension off from the tendon insertion. In a study this month, actually, they reported 10 feet in 9 patients using this technique, all of whom had a good satisfaction and managed to return to activity. So what about Achilles tendon rupture? Well, we've said that there are avascular watersheds underneath both retinaculum, and the most common area for tendon rupture, is 2 to 3 centimeters proximal to the insertion. So roughly sort of just about where the inferior retinaculum covers the tendon. The proximal end tends to retract and can retract quite significantly. Factors that are implicated, obviously, if you have a fracture in this area, there's not much tissue between the bone and the tendon, and this can cause ruptures. Consider inflammatory arthropathies, and that's certainly something that should be sort of fairly forward thinking for almost all of these tendinopathies if you can't quite have a clear picture of why they've occurred. Obviously, an exostosis in this area, attrition and avascular watershed from the inferior retinaculum, steroid injections, which we probably should not be doing around any of these tendon areas, and it's also more commonly reported in patients with diabetes. So how do they tend to happen? Well, for the traumatic ones in the younger patients, this is a forced or excessive plantar flexion against an already contracted tibialis anterior. In young patients, this tends to present with quite acute pain, decreased dorsiflexion strength, but often not with a significant, really sort of pronounced traumatic episode. In older patients, which is certainly, I think, where we see it more commonly, they may tend to develop a long-standing, fairly painless foot drop and may not have noticed a significant precipitating event. And when you look through these, there is often a 10-week plus delay from any history of start of symptoms to diagnosis. Clinical examination, often by the time they present, they've got a swelling over the anterior ankle, which is usually due to the bulbous end of the proximal tear. They usually have fairly minimal pain, but a decreased dorsiflexion or a foot drop. It may be that in some patients that the long extensors compensate for their foot drop and they haven't noticed a significant loss of function. Differential diagnosis is essentially between either a perineal nerve palsy or an L4-5 radiculopathy. So conservative treatments would involve around provision of an AFO or a foot drop splint. I personally find that in the elderly, they tend not to tolerate these and will tend either not to use anything and just get on with it or want something further done. There are lots of different surgical options described, from tenodesis through to free tendon grafts, often involving one of the short extensors in the foot. In a rupture, a direct repair is rarely possible, and that's because of two factors. One, the tendon end tends to retract a fair distance, and it's very difficult then to be able to get this under the retinaculum, and also because it forms a very bulbous end that doesn't heal well. I must leave my mouse alone because it obviously doesn't like being moved. So a variety of procedures have been described. One probably of the most commonest one is an EHL transfer, where more proximally the EHL is tenodesed side to side to the ruptured proximal end of the tibialis anterior. Distally, the EHL is then tenodesed to the extensor brevis tendon at the level of the first MTP joint. The long extensor is then detached and reattached through or at the medial cuneiform. As I say, you can also use free tendon grafts, and these have been described. My personal experience, and as I say, tend to see this more commonly in the elderly population, is most elderly patients tend to have little functional deficit, and even trying to persuade them to have something done is quite difficult. So moving on now to the Flexor Hallucis longus. So this comes from the back of the fibula and the interosseous membrane. It runs on the posterior aspect of the tibia and the talus, and as we all remember from our medical school days, it's beef to the heel. So it has a very low-lying muscle belly. It then runs posterior to the talus and inferior to the sustentaculum in its fibro-osseous tunnel. It then runs underneath the foot, crosses the FDL at the knot of Henry, and comes down to insert on the plantar aspect of the distal phalanx of the big toe. Again, vascular watersheds have been described, and these are at the back of the talus and around the region of the metatarsal head. So as we know, what does it do? It's the major plantar flexor of the great toe. It plantarflexes and inverts the foot. And this allows you to go up on your tiptoes and to control going back down. It controls the MTP joint, obviously, but it also acts to stabilize the subtalar joint in the midfoot. With regards to strength, the posterior tibial tendon is stronger than the FHL, which in turn is stronger than the FDL, and that can be important to know when you're considering tendon transfers. So FDL Chemosynovitis there are very few big series in the literature. It's mainly case reports, and it's mainly in ballet dancers. And you'll see a lot of these case reports either are by or quote a guy called Bill Hamilton, who was an American orthopedic surgeon who was surgeon to the New York Ballet and saw a lot of these problems and wrote them up. So it's also known as dancer's tendinitis. The main symptoms tend to occur at the region of the fiber osseous tunnel. It tends to be seen in dancers when they go up on point, so up on their tiptoes. And one of the feelings as to why they get symptoms in this area is that's where the tendon is closest to the sustentaculum. It requires quite a lot of tension and force to maintain this position, and there's an impingement type of pain at that region. So the tenosynovitis can be caused by tendon hypertrophy, synovial adhesions, a low-lying muscle, because we've seen it's beef to the heel, so the muscle can lie quite low, longitudinal tears, and nodularity. And often longitudinal tears and nodularity will coexist and can form stenosing tenosynovitis, where you get quite a large nodule just proximal to the fiber osseous tunnel, which can cause problems with tendon tracking. So how does it present? Well, usually as medial ankle pain, often with a feeling of catching and weakness on running or activity. As I say, in ballet dancers, it tends to occur when they go up on their toes into the on-point position. Clinically, they may have a thickening around the FHL sheath, a limited degree of IP joint movement, particularly if they've got a stenosing tenosynovitis, where the tendon won't run into the tunnel. They may have crepitus in this region, and they may have triggering, which is known as hallux soltans. And this can occur a little bit like a trigger finger in the hand, where the IP joint of the big toe tends to get caught in a degree of flexion. It can then extend with a clicking sensation and a catching sensation around the ankle, with soltans, as you all know, is derived from the Latin term for jumping. The main differential diagnosis is with posterior impingement, possibly with an ostrigonum. And certainly these can coexist and can give trouble at the same time. To differentiate these, the pain from posterior impingement tends to occur on full plantar flexion. With an FHL tenosynovitis, it tends to occur with a degree of plantar flexion, but combine that with great toe extension. Pain from the FHL tends to occur over the posteromedial ankle. Pain from posterior impingement tends to occur over the posterolateral ankle. There is a clinical sign called Thomasen's sign, not Thomas's or Thompson's, and this tends to occur when you get that stenosing tenosynovitis. So with the ankle in dorsiflexion, you lose NTP joint dorsiflexion, because a little bit like a stopper in a bottle, the nodularity of the tendon tends to sit at the neck of the fiber osseous tunnel, won't come through, and therefore big toe motion is then lost. So again, we've talked about conservative treatments, which are mainly rest and activity modifications. Obviously, in people like ballet dancers, this can be quite problematic. Any surgery is usually performed through a posteromedial incision, though endoscopic releases has also been described fairly recently. You need to identify the FHL and its fiber osseous tunnel. Remember that the clockwork of the neurovascular bundle isn't a million miles away. The sheath is released. You can then look at the tendon, excise any nodules, repair any longitudinal tears. There's some controversy as to whether you would excise an ostrigonum at the same time. And most people who would have investigated this, probably with an MRI scan, would leave us an asymptomatic ostrigonum alone. So an ostrigonum that didn't have significant surrounding fluid and didn't have any bone marrow edema within its substance. The results that we've seen are mainly in dancers, and the majority of these are able to return to their same level of activity. So let's move on to the perineal tendons. So we'll explore the pathology, we'll look at some treatments, and we'll also look at some of the evidence and perhaps some of the evidence which maybe will make us think a little bit as to how we deal with these, or exactly why we've dealt with them in the way that we've dealt with them. So a little bit like the Tendinopathy Consensus. This was quite a useful document from ESCA and the American Society, looking at perineal tendon pathologies. And this was based with a group of experts, all of whom had published on the subject, and all of whom did literature reviews and then put their heads together to come up with some thoughts based on the literature. So for perineal tendon problems, we should think about 3 different groups: tendinopathy, tears, and subluxations or dislocations. So they then asked, is there any relationship between the localized anatomy and the development of perineal tendon pathologies? And they said, well, yes, there is. They felt that overstuffing of the perineal tunnel was important, and this can be caused by things we're going to look at, such as a low-lying muscle belly of peroneus brevis, accessory muscles, the shape of the retromalleolar groove and the fibrocartilaginous ridge, potentially an enlarged perineal tubercle, and the sesamoid os perineum. So looking at the anatomy, the perineal tendons form the lateral compartment of the lower leg. They're innervated by the superficial perineal nerve. They are vascularized by both the posterior perineal artery and the anterior tibial artery. Looking back through the literature, there were classic watershed avascular areas described in the peroneus brevis, just distal to the lateral malleolus, and in the peroneus longus, around the region where the tendon takes a 90-degree curve and runs underneath the cuboid. But more recent vascular studies have not confirmed that this is actually the case. So in the supramalleolar region, both tendons run in a common synovial sheath. And this runs from about 4 centimeters above the medial malleolus to 1 centimeter distal to the medial malleolus. Within the supramalleolar region, the brevis has a lower muscle belly, it's a flatter tendon, and it tends to be, and it's closer to the bone. So this is obviously important if you're exploring the area and you want to make sure that you know where your peroneus brevis is and which one is your longus and which one is your brevis. So brevis, starting with a B, closest to bone. In the retromalleolar region, this is where they tend to run in a slightly more fibroosseous retromalleolar groove. And this is comprised of the superficial perineal retinaculum, which is the primary restraint to tendon subluxation. There is also a fibrocartilaginous lip, which tends to help to deepen the retromalleolar groove. The retromalleolar groove at the back of the fibula, in which the tendons should sit, is usually concave, up to roughly about 80% in the literature. In some patients, it's flat, and in some patients, it's actually convex. When it's concave, it has an average depth of 3 millimeters and is about 1 centimeter wide. So this is the important area when considering perineal subluxation and dislocation. So the superficial perineal retinaculum tends to stick the tendons down in their fibroosseous tunnel with the back of the fibula and blends with the periosteum. Below the medial malleolus, the tendons separate and they run in 2 distinct synovial sheaths. As they run down towards the foot, they're separated by the perineal tubercle, and in this region, the perineal sheaths thicken to form the inferior perineal retinaculum on the side of the calcaneum. The brevis then runs down to the dorsolateral aspect at the base of the fifth metatarsal. The longus passes in its fibroosseous cuboid tunnel and is covered by the long plantar ligament, and then runs across the foot to attach to the plantar lateral base of the first metatarsal and the plantar lateral aspect of the medial cuneiform. An os perineum is a sesamoid bone, which is seen in approximately 30% of patients. It runs in the peroneus longus, just in the region of the cubital tunnel. It tends to articulate with the inferior cuboid, and a little bit like the sesamoid bones in the big toe, can be uni, bi, or multipartite, and can consist of both bone and fibrocartilage. You'll hear the term POPS, painful os perineal syndrome, which not only relates to the os perineum itself with acute or chronic fracture, but it can also relate to a tear of the peroneus longus in the region of the cubital tunnel, an avulsion rupture where the peroneus longus avulses from the os perineum, with the os perineum retracting proximally. It can also relate to an enlarged perineal tubercle and tenosynovitis in the region on the outside of the foot in the inframalleolar region without a tear or rupture. So there are significant anatomical variants in this region. The commonest is a low-lying muscle belly on the peroneus brevis, and the muscle then comes down and runs in within the superficial perineal retinaculum. Obviously, as the tendon courses through the retinaculum, this will vary with foot position. And a low-lying muscle belly has been reported in approximately 1/3 of patients. There's also some accessory muscles, the peroneus quartius or the quintus, which tend to come from higher up in the leg, often from the peroneus brevis muscle itself. They tend to run posteromedial to the peroneals and attach either on the calcaneum or base of fifth metatarsal or peroneals or the inferior retinaculum. These tend to occur in approximately 1/5 of patients. So both these conditions may overcrowd the retromalleolar groove and can be associated with an increased incidence of laxity of the retinaculum with subluxation, and can also be associated with underlying tears and tenosynovitis in the main two perineal tendons. So what do the tendons do? Well, brevis primarily is an everter. Whilst there's some controversy as to which of these is the most powerful, the brevis in most cases has been shown to perform approximately 60% of total eversion power. Obviously, it's an ankle plantar flexor as well. The longus will evert the foot and has a degree of stability of the first ray. It stabilizes the medial column in stance, and this is thought to occur by locking of the first TMT joint. One thing that it probably doesn't do, but it's written up in all the textbooks, is actually cause significant plantar flexion of the first ray in a cava varus foot. Because if you think of the course of the muscle and the fact that it tends to take a couple of 90-degree turns and inserts on the proximal aspect of the first metatarsal, it's unlikely to have a significant plantar flexing action unless this is this occurs dynamically. So both tendons are controllers of dynamic stability of the lateral ankle complex. So they obviously act in concert with the lateral ligaments. They're the first muscles to contract during sudden ankle inversion. So when we come to clinical examination, obviously there are a variety of things that we're looking for. in regard to tendon pathology itself, but also to mainly overall alignment of the lower leg. So in the majority of patients who have problems with the perineal tendons, they will have a degree of varus. Now, you've got to consider as whether this is a cause or an effect. So is this varus caused by weakness of the perineal tendons and possibly associated with lateral ligament laxity, or is this varus a cause for causing perineal problems? As with any hind foot deformity, particularly a varus deformity, we've got to work out whether this is fixed or flexible. And this is where your Coleman block testing is important to find out whether this is a hind foot driven or a forefoot driven deformity. We've also got to try and ascertain whether there is any potential underlying neuromuscular disorder, such as Charcot-Marie-Tooth. Do they have a significantly plantar-flex first ray? Is there intrinsic muscle wasting? Is there clawing of the lesser toes? And is there any muscle wasting higher up the leg? Don't forget that a valgus deformity, so typically occurring with tibialis posterior tendon dysfunction, can cause subfibular impingement as the calcaneum drifts into significant valgus. You can also have problems with the perineal tendons post-calcaneal fracture, particularly with a malunion with a widened broad heel. So we've got to test inversion eversion and inversion eversion power. We've also got to perform anterior draw and inversion tests, stress tests, to look at the integrity of the lateral ligaments. And often patients will be able to help you. They may well be able to perform trick maneuvers, particularly with eversion and dorsiflexion, which can cause subluxation or dislocation of the perineal tendons across the lateral aspect of the fibula. If they have any other catching, they can quite often circumduct the ankle and cause this clicking or catching to occur. So how are we going to investigate these patients? Well, obviously, if there's a traumatic event, or usually if they come to clinic, they will have some plain radiology. What can we look for? Well, obviously, any cavus deformity, whether there's the presence of an os perineum, which is usually best appreciated on a internally rotated, non-weight bearing oblique view of the foot. You can occasionally see an enlarged perineal tubercle, though this is quite difficult on a plain film. And you're also looking for mimickers of tendon pathology, or mimickers of posterior hind foot pain, such as a stress fracture, a coalition, or osteoarthritis. One thing that is pathognomonic of a perineal tendon dislocation with an avulsion of the superficial perineal retinaculum is the flex sign with an avulsion fracture, longitudinal avulsion fracture from the lateral aspect of the lateral malleolus. The next investigations that we can perform, an ultrasound. This is good for dynamic testing, and obviously depends on the experience of your sonographer. It's very good for looking at intersheath subluxation, and is often good for looking at frank dislocation of tendons as well. A CT scan, probably not as commonly performed, but is good to look for osseous anatomy, and this is probably most likely to be performed after you're querying lateral wall impingement from a malunited calcaneal fracture. MRI scan is obviously often our go-to. It's good for concurrent pathology. It will be able to try and pick up tendinopathy and chemosynovitis with increased intratendon signal and circumferential fluid, mainly running around both tendons. One thing that can be quite difficult if you're not looking at the sections yourself is because of the curved path of the tendons, particularly coming around the lateral malleolus and underneath the cuboid. That can decrease the sensitivity and specificity of picking up subtle abnormalities and small tears. Don't forget that up to 35% of perineal tendon pathology may be asymptomatic. So take your radiological findings in concert with your clinical examination. So looking back through the consensus statement, they've asked, what are the key features to diagnose perineal tendon pathology? So in an acute episode where there's a suspicion of perineal tendon pathology, clinical physical examination combined with Ottawa ankle rules if appropriate, a specialist review at 2 weeks if unable to weight bear from a traumatic event, and only an urgent specialist review if there's a flex sign seen, a clear history of a clear history of a popping sensation or frank dislocation, which can be picked up on clinical examination. And both MRI and ultrasound scan, they say, are appropriate investigations. For those patients that go further down the line with normal examination, normal MRI scan and ultrasound, they would reserve tendoscopy for those patients with a high index of suspicion of perineal problems, but normal radiological investigation. So there won't be many of those. So if we consider splits and tears, there are essentially two suggested etiologies. One is where you have subluxation of the tendons and the peroneus brevis gets caught on the fairly sharp edge of the lateral fibula and gets an attritional rubbing, which causes a longitudinal tear. The second is where you get an inversion injury and you get compression of the peroneus brevis tendon against the back of the fibula by the peroneus longus. The vast majority of tears are seen in the peroneus brevis, though about 40% have tears of both peroneus longus and peroneus brevis concurrently. You may see the Brandes-Smith classification being used, and this essentially is based on zones of injury. So in the region of the retromalleolar region, where you've got the superficial perineal retinaculum, you may get problems with subluxation or a mass effect. In zone B, which is the inferior region, this may be related to perineal tubal hypertrophy. And in zone C, at the region of the cuboid, this is where you get peroneus longus pathology. So with our peroneus brevis here, you can see there's a slightly sort of nodular edge. There are these longitudinal small slits and tears, but the tendon itself tends to be in continuity. What you tend not to get is complete ruptures of the tendons in this area unless there are long-standing multiple longitudinal splits. So tendinopathy will tend to present with thickening, swelling in the regions, and as I say, mainly in the retromalleolar or inframalleolar regions. Again, treatment options, activity modification, orthotics, anti-inflammatories, and possibly rest within a walking boot. Synovectomy can be performed, and we must deal with associated pathology. The majority of these patients who come to surgery will have an open incision. It's important to allow repair that you keep a small area, certainly with the fibrocartilaginous cuff on, so that you can get a strong repair once you've performed any surgery that you need to your perineal tendons. With splits, you can debride the split. If you have a partial tear, you can excise the tear, and sometimes you can just leave it at that. usually you'll find a longitudinal split which has gone right through the tendon. You've then got to decide really which of these parts is the most normal, and usually excise the most abnormal part. You can then, you've usually then left with a fairly flat tendon, often with some attrition on that part of the tendon, and you can tubularize this tendon. So you're taking a flat tendon and you're making it cylindrical with a technique usually involving a vicral suture. So classically, the teaching would say that if the residual tendon is fairly poor, or you're left with less than 50% of a normal tendon, that you should perform a tenodesis of the peroneus brevis to the longus, because it's usually the brevis which is the most diseased tendon, and do this above and below the lateral malleolus so you don't get any impingement within the retromalleolar groove. So here's just an illustrative case. This is a young rugby player who had a significantly swollen and enlarged perineal tubercle with his perineal tendons, particularly his peroneus longus in this case, draped over this edematous enlarged perineal tubercle. He's already previously had a syndesmosis stabilization. This was opened, the sheath was opened, and you can see this large, very bulbous tendon. When you turn it around, you can see the attritional nature of the tubercle on the tendon itself. So it's a longitudinal split with the tendon essentially in continuity. The central area was excised. The brevis tendon actually was in fairly good condition, and the tendon was then tubularized to try and make a more normal looking tendon, trying to wrap up the diseased tendon in the middle in a way. And this enlarged perineal tubercle was then resected and covered with bone wax. So this is this is an algorithm that you may see from Redfern and Meyerson from back in 2004, which concerns what we can do if one or both the tendons are unusable. And as you can imagine, sort of, it's coming up to nearly 20 years. Some of the things that they described were such as using silicon rods to create pseudosheaths, not so frequently used now. And this has been sort of superseded by an algorithm, again, from this ESCA group. So as we've noted, nearly a third of patients will have asymptomatic tears and they don't need any treatment. This group suggests that even if a tendon has less than 50% of its normal bulk, that it's worth performing a primary debridement or a tubularization, and that this can give good outcomes and return to activity, even up to only 30% of the tendon remaining viable. If repair or tubularization isn't possible, they would then recommend a single stage hamstring autograft. They have concerns with the use of allograft in terms of tendon incorporation to the distal and proximal ends, but also over time with creep within that tendon, which, as you know, is a concern also with the use of allografts for anterior cruciate reconstruction. They have advised, if possible, not to perform a tenodesis because this fairly recent cadaveric study showed that a tenodesis does give insufficient normal tension, and that a graft is much better at restoring normal tension. If you are going to perform a tenodesis, it's much better and you get a much stronger and better tensioned repair if you tenodese longus to brevis rather than the other way around. If neither tendon are present or they're irreparable, then certain groups have recommended performing attendant transfer, harvesting the FHL or the FDL in the foot and then bringing it round to the lateral aspect of the foot, and usually plumbing it into the base of the fifth metatarsal or the brevis stump. Long term, this is shown to have strength and balance deficits, though if no other option is available, then this can be an option that can be used, but obviously will not restore full function. If we're thinking about excising an os perineum, then the surgery is performed just around the region of the cuboid. The os perineum is then shelled out. Usually, I personally find that once you've shelled out a symptomatic os perineum, there's not a lot of good tendon left. The peroneus longus is often ruptured. The distal end has gone underneath the foot, never to be found again, and the os and the proximal tendon has retracted slightly proximally. In this case, you excise the diseased tendon and perform a proximal tenodesis to the peroneus brevis. So, as we mentioned earlier, the POP syndrome, the painful os perineum syndrome, covers quite a variety of different pathologies and quite a variety of different treatments, but essentially involves excising a symptomatic os perineum, trying to maintain the tendon, the peroneus longus tendon if possible, but if not, performing a tenodesis, excising an enlarged perineal tubercle, and again tubularizing or tenodesing diseased tendons in this region. So lastly, we'll touch on perineal subluxation and dislocation. So these often occur when the ankle is in dorsiflexion with associated hind foot inversion, when the perineal tendons tend to violently contract, pushing the superficial perineal retinaculum off the fibula. These have been graded into three different anatomic grades. The most common of which are grade 1 and 2, where the superficial perineal retinaculum is stripped with the periosteum off the fibula, allowing a space for the perineal tendons to sublux into. In the first type, the cartilaginous rim remains attached to the fibula. In the second case, the retinaculum and the cartilaginous rim are pulled off. In grade 3, this is where you see that flex sign of the distal fibula, where there's a bony avulsion as well, which is slightly less common. And the fourth type, which is where there is a posterior defect of the retinaculum, which is even less common. So the majority of these do fairly badly if they're managed conservatively. It may be worth those with the bony avulsion, putting them into plaster and see if they settle, but greater than 50% have a redislocation or subluxation rate. You could in fact perform what's now become known as the Schilling procedure. This guy was pitching for the Boston Red Sox in some important baseball games, dislocated his perineal retinaculum. Before every game, they filled him up with local anesthetic and sutured his skin down to the periosteum of his fibula. He would tend to bleed during the games, and that came through his, I guess that's perhaps why they were called the Boston Red Sox. But apparently he managed to see out the end of the season before having his definitive surgery. So an interesting way to get around this problem. But this is usually performed through an open incision just posterior to the fibula, directly over the perineal tendons. The superficial perineal retinaculum is incised, leaving a cuff of tissue for repair. You then want to not only stick the perineal retinaculum back to the fibula, and this can be done with suture anchors or through bone tunnels, but you want to shorten and repair the lax superficial retinaculum to keep the perineal tendons in place. In patients who've had chronic subluxation, it's often easier to do this as the superficial perineal retinaculum becomes very voluminous, and you're often able to double breast this repair. It's often associated with a retromalleolar groove deepening, particularly in those patients who have a flat or a convex groove. This can be done either through a trapdoor type opening and then removing some bone and then tamping down the back of the fibula, or it can be done by through the tip of the fibula, putting a large bore drill through, removing some bone, and then doing a direct tamp down without actually performing the trapdoor procedure. So who should have what? So the ESCA group in dislocations. So in the non-athlete, they suggested that conservative treatment could be tried. For those undergoing surgical management, an open relocation, and you could consider not doing a groove deepening. But in the athlete, they recommended that an athlete underwent a groove deepening procedure in order to decrease any risk of further dislocation. So what about the varus hindfoot? Well, the majority of patients who have atraumatic perineal tendon pathology will have a varus hindfoot, and that's up to 80% in certain series. And as I've mentioned before, this has got to be part of your careful clinical examination. Who should have it though? Well, interestingly, and this group particularly was concerned with athletic treatment, they noted that it's well recognized that varus is associated with perineal pathology, which we know. They've said that there's no evidence that the isolated effect of a calcaneal osteotomy can improve perineal tendon pathology. They suggested that hindfoot realignment should be reserved for those patients with symptomatic varus or even valgus with subfibular impingement that's associated with joint degeneration and or significant ankle instabilities. They suggested that any hindfoot realignment and calcaneal osteotomy should be avoided in athletes because athletes commonly have asymptomatic idiopathic varus, and if this is corrected, this may actually put them in an abnormal position for them, which may have a detrimental effect on their athletic performance. So just finally, before we close, over the last few years, this phenomenon of intersheath subluxation has been recognized, where within a normal perineal retinaculum, the brevis and longus reverse positions. And this is noticed by a clicking sensation, which can often be painful as the patient circumducts their ankle. This is useful to have dynamic ultrasound scan, which can show this flicking phenomenon quite nicely. It's very difficult to get to settle, I think, with conservative treatment. Most of the small descriptions of case studies have described performing groove deepening procedures just to give the tendons more room to move. In the few that I've done, I've also just flapped back a flap of periosteum from the fibula and secured it with a suture anchor between the brevis tendon and the longus tendon just to keep them apart. So just as a final thing that I wanted to point out, please remember in these patients that you may be dealing with an unrecognized inflammatory arthropathy. This was a professional footballer who presented with a completely ruptured peroneus longus tendon. You can see that his sheath is completely empty, lots of fluid around his brevis tendon as well, complete rupture of his longus tendon, and also presented at the same time with a significant effusion in the knee, which wasn't associated, which was uncommon for a professional footballer, wasn't associated with any significant underlying pathology, and he turned out to have a psoriatic arthropathy, and that was his first presentation. So in conclusion, tendon pathologies are common in the foot and ankle. Many will respond to standard non-operative treatments. The literature, though, is often incomplete and based around fairly small historical case reports. In the future, hopefully, we'll have a better understanding of the process of tendinopathy and its healing, and improved classifications of tendon disease will help clarify our thinking and decision making. So thank you very much. I know I've run on for a fairly long time.
Yeah, thank you very much, Rhys. That was full of information, and what we found from feedback is a lot of people are listening to this on a replay mode, and they're listening to this late at other times. And I think it's well worth re-listening to this lecture because there's so much detail in it. So we've got a few minutes for some quick fire questions. When we're talking about tibialis anterior, I liked your TAPS test. But if an athlete presents to you with an interval between injury and presentation, how long is the time that you would allow before thinking of attempting a primary repair in a younger person? When do you have to give up and say time for tendon transfer?
So I think, Rick, as we've said, quite often even the younger patients tend to sort of take a bit of a time to present to you. The tendon ends tend to retract, in my experience, quite a fair bit, and the proximal end particularly becomes quite bulbous, so and fairly atrophic fairly quickly, so it isn't great. So I think it's very difficult to gain the length to do a primary repair unless you see these patients within the first 1 to 2 weeks, it's often the only thing that you can do is to perform a tenodesis or a free tendon graft.
That's why I think your point about the TAPS test and people starting to think about this and trying to get early recognition is important. Quite a technical question from Mr. Gajula. How do you differentiate FHL tenosynovitis from intersection syndrome? And intersection syndrome, just for people viewing, is the inflammation and damage at the master knot of Henry, a little bit further down the foot. How can you distinguish between those two?
So we didn't really sort of talk about anything further down than the interosseous tunnel. It is quite a difficult differentiation, and I suspect it's probably it may well be part of the same process, and it's just been sort of classified too finely. In terms of clinical examination, I think it's very difficult, particularly where you've got vinculi in that region, which run between the FHL and the FDL, which often make clinical examination of one or the other very difficult at that level. So you're either looking at the help of a very good ultrasonographer, or trying to pick something up on your MRI scan.
Okay, and a lot of the audience spend a lot of their time fixing ankle fractures, and we've had a question asking, have you ever seen any problems with posterior fibular plates causing damage to the perineal tendons, and any advice as to how to avoid that? This has to be a quick answer, I'm afraid.
I have. It's certainly very well documented, and when we started sort of plating posterior fibular fractures and doing posterolateral approaches, it was something that a lot of people were concerned with. I think with the use of low profile plates and not trying not to get down into that sort of region of the retromalleolar groove is important. So, trying to sort of, make sure that you don't put metalwork in that area where the tendons actually need to glide around the back of the fibula.
And then sticking to the perineal tendons, a question, how long would you persist with non-operative treatment for a peroneus brevis tear? the duration of your non-operative treatment? I know you said it was more than 50%, you'd be more keen to operate, but if you're doing non-operative, how long is that?
Well, you know, so obviously some of these, as we said, you know, some of these may be a red herring. It may just be picked up on an MRI scan or an ultrasound scan. You know, my feeling is that you know, as with all these things, it's, you know, it's a bit of sort of informed decision making with you and the patient, really, isn't it? And you know, there's a lot of factors that that you would take into account with regards to that. You know, my feeling is, you know, having a significant waiting list, is that quite a lot of these patients that you actually list for surgery, I would say by the time they come round to wanting surgery or having surgery, have often got a fair bit better actually with their own activity modifications.
And the final question is going to be a bit of a Marmite question. I've had a question about shockwave therapy, and in the foot and ankle world, people either love it or hate it. Do you think there's a role for shockwave therapy for the perineal tendon?
I've personally never used it. I think it probably has got a bit of a role in the insertional tibant issues, but I've never used it for perineal tendon pathology.
No, I'm a believer, but for Achilles tendon and plantar fasciitis, I've never used it laterally. So I'm sure there'll be a plentiful area to research into. Thank you very much, Rhys. That takes us up to our hour. I think when we look at the plans for season 2 of the Lectures of Distinction, we may have to divide that massive topic into 2 different evenings. But thank you very much for your expertise and your very eloquent lecture this evening. I'd like to remind everybody that next week, on Tuesday at 8 o'clock, we have Peter Rosenfeld from London, and he'll be talking about heel pain, which is, again, a very common condition that we all see and we all need to know a lot about. So thank you very much for joining us this evening, and I hope you look forward to next week's BOFAS Lecture of Distinction.
Thank you very much, everyone. Thank you for your attention.